So what job is different from day to day. So I have different parts of my position. Some of them are clinical responsibilities, and some of them are research related, and then some of them are administrative. So as part of my clinical responsibilities, my primary role is as the associate medical director for inpatient genetics. So I oversee the consult service for patients that are admitted to Seattle Children's Hospital or at the University of Washington in the NICU. And when the medical teams feel that there is a clinical indication for a genetic evaluation for the babies or the kids that are admitted, they will call our consult team. So sometimes I'm on service for that clinical team. Sometimes I'm not. And then for my outpatient clinics, I have a few different clinics that I do. One of them is related to vascular anomalies, and there are a number of genes that we now know are associated with both neurological changes as well as vascular malformations. And we have some precision medicine therapies that we have approved for use in some of those kids. So that's one of my clinics. I have an inpatient follow-up clinic where I see patients a half day, a couple times a week, and then a clinic for just general genetics as well. When I'm not seeing patients, I primarily will see patients I have collaborations with investigators all over the world. And depending on the day and which project we're working on, I spend a lot of time talking to people at these different sites about our projects and do academic work related to those. From a research standpoint, the project that I spend a little time every day and a lot of time on some days working on is a sequencing first project, SeqFirst. And what we're doing is we're enrolling patients. We screen all the patients who are admitted to the NICU at Seattle Children's, and then we offer rapid genome sequencing for really all of the babies that are admitted whose clinical picture can't be fully explained by prematurity, trauma, that kind of thing. And then we're doing rapid sequencing for that. So that launched about 2 weeks ago. So a lot of my work, my daily life up until these last couple of weeks has been getting that project off the ground with IRBs and all of that. But we've just started to enroll and have data start to come back from those patients as well. So the amount of time I spend clinically varies day to day. And then research day to day. And then I'm also an associate program director for the pediatric residency program for research scholarship in pediatric genetics. So I have administrative responsibilities related to the research track for the PEDS program and our combined PEDS genetics residency. So those kind of come in on a daily basis. I show up at different times. That's a great question. And I think it's really timely. It's something that as a medical community and as a hospital, we've been spending a lot of time talking about equity and trying to look inward to look at the way that our institutions are set up in a way that is not equitable and how we can improve that. I think that some of the things are broad and are hard to pin down concretely because there are groups of people who traditionally have not been treated equitably in society at large, and also within medicine and also within research, and that people within those communities are inherently less trustful many times of things that we say. And this, has come up for me a couple times this week just on clinical service, where you can see that people who have lost trust in us as physicians receive news and receive recommendations very differently. So I think that part of it is backing up from specific fields of medicine. I think as a society and as a community, we need to acknowledge those experiences, and that the reason there is distrust is because we have not been equitable, like as a group, and that there have been things that are just not fair, and owning that and trying to move forward from that, I think is important. concretely, we know that people that can pay out of pocket for therapies and people that can pay out of pocket for additional therapies beyond what's happening in school and can pay out of pocket for genetic testing that are insurance authorized and can fly across the country to access the best experts in their particular area, their kids are going to have better outcomes. It just is, and we currently don't have a lot of ability to make that more equitable because of financial constraints. And even just a matter of how do people get to their appointments? How do people get to their therapies? Right now with the COVID pandemic, who is still getting therapy? Some people who are able to organize it over Zoom are able to make it a priority, are able to have enough childcare to be able to free their kids up to be able to do that, or send their kids to private schools that can have them in classrooms. And I think that equity is going to be a huge piece after this pandemic is over, seeing how the natural history of these conditions has changed just based on what parents are able to access. So concretely, things we can do, I think that we need to have better access for clinics in communities where people live, where they don't have to travel very far. I do think telemedicine is going to help because people are able to do telemedicine appointments like from work. They can often, I did a visit on Monday where mom had to work. And so she, on her break for 20 minutes, she ducked out, baby from home, Zoomed in with the kid, and we just worked it out together. I think we need to have more access for evening, weekend appointments. We've even talked in genetics about potentially doing mobile clinics, trying to get into the communities to make access better. And then improving funds to be able to pay for things that families who have the means to be able to pay for extra therapies, genetic testing, all those kinds of things. We just need to be able to have more financial resources to be able to do that, so that kids in all different groups can achieve their best potential.